Hi, everyone. I'm just giving everyone a minute or two to join, and then we will be starting today's exciting webinar. So my name, for those who don't know me, is Kelly Du Plessis. I'm the founder and CEO of Rare Diseases South Africa, and I'm really, really delighted to be having asked to chair the session today. Today, we are going to be discussing advocacy for congenital disorders and rare diseases within Sub-Saharan Africa. And this is going to be an expert discussion, and I'm going to stress the point, discussion, because we find that it is imperative that we are able to come together, collaborate, network, and really discuss and get to the bottom of the issues that we face on a day-to-day basis within this context. This webinar has been brought to you by the Sub-Saharan African Congenital Anomalies Network, further known as SCAN, and the Global Health Network from the University of Oxford. We do have some really, really interesting speakers joining us today who are going to be sharing some of their experience. But I think most importantly, and really, really important to stress, is once again that we are wanting that engagement. We are wanting to hear from you as the audience, and we are really, really wanting to be able to, get together, take some questions and answer, etc. So just a little bit of housekeeping rules. This webinar is being recorded and it will be shared on the Global Health Network platform. For use of the chat box to introduce yourself or for any technical issues. So the chat box can be found if you are on your screen. I think all of us have now done a Zoom call at least once or twice, but at the bottom, there's that little taskbar. You will be able to find chat. If you click on the three dots that says more, you'll find the chat box, and you are please more than welcome to introduce yourself. Let us know who you are, who we're speaking to, where you're from, etc. If you like, you can also share any of your contact details if if you're wanting and comfortable to do that. Please use the Q&A box when it comes to actually registering your questions. You are able to do this anonymously. So if there's a question that you'd like to ask anonymously, please do so. It's imperative that we use the Q&A function, which can also be found at that bottom taskbar, to ask these questions, simply because of the fact that it makes it a little bit easier for us to track when moderating the session. So please, if you are wanting to put questions forward, make use of the Q&A function. And then, due to the number of participants, cameras and microphones have been disabled, but typing hasn't. So chat away in that chat box. And hopefully, if we have enough time, which I'm sure we will, there will be a Q&A session. Should you need to want to ask anything verbally, you're more than welcome to do that at the end of the session, provided that we have time. But I would say, just to be safe, rather submit your question as a Q&A, and if necessary, if we feel we can take it as a verbal oral question, we will do so. So we're looking super forward to today. Right, so I'm going to just do a brief introduction of our speakers, and I'm going to also just say that we made the decision to not do a formal bio read in terms of introducing. We are actually going to allow the speakers to give you a little bit of context as to who they are in their own words, simply because of the fact that it just helps us building that network when you hear it from them directly. So next in line is going to be Dr. Ahmed, who's the country director for Reach for Another Foundation based in Ethiopia. So Dr. Ahmed, over to you.
Hey guys, thank you very much for this opportunity to be here. I think I'm audible, right? Can you hear me? Yeah.
Coming through loud and clear.
Okay, thank you very much. I am Jacob. I'm based in Addis Ababa, Ethiopia right now, and I'm a public health PhD researcher, I can say, recently, and I've been in a health system in Ethiopian Ministry of Health almost for a decade. My recent post in the government was Director General for Health Services at the Federal Ministry of Health for 2 years, and I also work as a hospital director for a couple of years. So that's where I really get interested into this birth defect, specifically neural tube defect, spinal bifida, hydrocephalus, anencephaly, and all related complications when I was a hospital director, and then became the Minister's Health Service Director. Then I tried to expand the service in the country. And now recently, I assumed this position, Reach Another Foundation country director position. And this organization is specifically working on prevention, treatment, aftercare, and evidence generation in the area of neural tube defects, specifically spina bifida, hydrocephalus, and other neural tube defects all over the country. And we really collaborate with university hospitals. We have 8 university hospitals working with, and also with the Ministry of Health, and also state health bureaus. So I'm here as a researcher and a program manager for birth defect, specific neural tube defect, and I would be very happy to share you my experience throughout the panel session. And thank you very much for the opportunity as well.
Thank you very, very much. So if I can, I'm just going to, I am having a bit of a technical glitch here myself. I just wanted to ask, how are you involved in advocacy in your country, and what advocacy activities are you involved in from an Ethiopian space? I mean, this would be, I don't as routinely in my role see many advocates coming through from the Ethiopian space. And I think what's really, really imperative is that advocacy takes place in such a variety of different shapes and forms. I think, initially people have this perception of what advocacy looks like, and then advocacy on the ground looks nothing like you think it's going to, right? So I'd be very interested to just, if you would answer, what does advocacy look like in your particular region?
So I think this is a very exciting question, especially in a public health problem like birth defect, when they're really shadowed and overwhelmed by other public health problems. So the importance of advocacy is like irreversible, because they're really under communicated and less addressed in the health across the health system, and also overlooked over other public communicable health problem and communicable health problem. So advocacy is, I can say, a very crucial part. So in our side of the world, I can say there are a very good startups in terms of advocacy, and still we have to go a long way, especially to influence top policymakers and policy change. So I can say in our region, especially in Ethiopia, so advocacy starts with raising awareness. Like, knowledge is a key in terms of knowledge in the community, knowledge in health professional, knowledge in policymaker, knowledge in everyone is a very key. We believe raising awareness is the key part of advocacy. So that's how we believe, and we have so many educational campaigns in terms of birth defect in general, and specifically with neural tube defect. So one of the tool we're using, I can say, is, for example, upcoming, October 25 is World Spina Bifida Day. So we have kind of a week, Spina Bifida Education Awareness Week, from October 22 to October 27. So this is just a simple example I just want to mention. So this happens every year in the past couple of years. So we use that week to have a very good awareness creation educational campaign where professionals, public health experts, neurosurgeons, because this is very important for the neurosurgeons, and as well as the community members, support groups are part of this campaign. This is one important. The second important part in terms of knowledge improvement is, as we all know now, is a digital world. People are very much connected with internet and social media, and also mainstream media. So media and social platforms are other tools that we are using, especially to raise knowledge. As I said, raising awareness, knowledge is a key in terms of when we talk about advocacy. This is one part. But the other part, very important part I just want to share, is we are trying to bring everyone together. That's, we call it, by building partnership, you can really advocate for any public health problem. If you see the experience in the past, especially in the big public health problem like HIV, AIDS, tuberculosis, malaria elimination, so you can see how coming together, how partnership can really influence policymakers, funders, health professionals, even private insurers, and everyone to bring some specific public health problem into decision table. So we when we talk about this birth defect, we are trying to work with the Ministry of Health to create a kind of partnership between all stakeholders, like development partners, implementing partners, health facilities, professional association, some support group like family support groups to come and discuss this specific thing. So this is how we really trying to address. When we talk about this partnership, collaboration, one of the critical component is, connecting, the information, the knowledge we have with the affected community, because the affected community is the primary owner of this specific health problem. A mother with a child having any kind of birth defect, congenital heart disease, or neural tube defect, call it like cleft lip, cleft foot, whatsoever kind of birth defect, that mother is really a powerful advocate for that specific problem. So in partnership, we are trying to bring families, affected community parts, support groups into the partnership part in collaboration with the Ministry of Health. So this is one thing that we're trying to work. The last one I just want to make is policies are very crucial in a country. So if we are talking about birth defect, so what the policy of that specific country says. For example, in the area I'm working, neural tube defect or spina bifida, hydrocephalus, majority of the cases are preventable. Science has discovered neural tube defect, a significant proportion of neural tube defect can be prevented by folic acid and, supplementation, or food fortification with folic acid, or like by prescribing high-dose folic acid. But this is not like a magic to happen by itself. There should be a policy ownership in the country, like putting folic acid supplementation as part of antenatal care program, or adding some micronutrient like folic acid in routine food item, or at least high-risk prevention like prescribing high-dose folic acid. So what we did is, with the partnership, with the stakeholder collaboration, we work with the Ministry of Health to change some policies in terms of fortification. So now we did like successful advocacy, but the Ethiopian Ministry of Health decided micronutrient fortification of wheat flour in the country, and they big advocacy result. Proudly say Ethiopia huge progress on that, and now we are also can be reached only in a proportion of community. So we are also pushing to make a double fortification of salt with iodine and folic acid. Then there is a huge study undergoing led by the Ministry of Health. So you can see how our advocacy can really make a change if we are successful in the coming year, and then we can prevent majority of the public health problem. This is how we work in terms of advocacy in our side of the world.
Thank you very much for that comprehensive overview. I'm hearing collaboration and education being critical elements. I'm going to hand over, if I can, to Ms. Claire Bangarana, to the Director of Research and Knowledge Development at the AfriChild Center in Uganda. Love Uganda. So please, Claire, if you can just give yourself a very, very short introduction, if you wouldn't mind.
Sure. Thank you very much. Hello, everyone. Good afternoon, good morning, depending on where you are. My name is Claire Bangarana. It's 4 p.m. in Uganda. I work as the Director of Research and Knowledge Development at the AfriChild Center. I'm a researcher myself, a child protection researcher. I've done research for the last 18 years plus in child protection across different spheres, including public health, including justice and social protection broadly. I've also done research beyond Uganda. At the AfriChild Center, we are a child-focused research institution at Makerere University in the College of Humanities and Social Sciences. It's a bit different from what you would expect or who you would expect to be speaking to you about rare diseases and birth defects. Our focus, how we get into this work is our first entry was we were doing research. There was a national survey. Those of you who have heard about the national survey on violence against children, we were leading that in Uganda with the CDC. And as we went along, we discovered there are certain contexts where this survey, it's a large household survey, that typically doesn't go to certain areas. And then we decided to do complementary studies. That's how we came across a group of children that have been neglected in a lot of researches, a lot of large studies. And these were children with different types of disabilities. And so we did a study and collected some qualitative data on their experiences of violence. Unfortunately, our entry point into this work has been through disability, children with disabilities. So as we work backwards, we hope to get to the conversations around prevention. We also know there's a lot of work going on in Uganda. So as AfriChild, we do two core things. Our core business is research or generation of evidence, and two, promoting the use of this research by policymakers and practitioners. So we do implementation research, and we work across the spheres of health, gender. Children largely fall under the Line Ministry of Gender, and then education. And then we have several cross-cutting issues, and we acknowledge the intersection. So my hope is that even at the end of this conversation, we acknowledge the intersections that children end up experiencing as a result of birth defects and everything else that, you know, that is supposed to happen before they're born. So we recently also conducted a study. So I said our core business is research. So our entry point is evidence generation for policy information. So our advocacy efforts are hinged on the evidence that's available. Again, sadly, we don't have a lot of evidence coming from Uganda on birth defects. There are a few papers that have been done. So as we go along, we'll explore some of the other challenges that are affecting advocacy efforts on this, in line with this. So we generate the evidence. We've recently concluded another study building on two previous work, looking at children in refugee settlements and specifically children with developmental disabilities, and really their functional or status, access, issues around access to services, what services are available to them, and we'll be happy to share that also as we go along or much later on. So that's how we get into this work. I don't know if that's a very long introduction.
No, it's very, very interesting. And I think really highlights an important issue around, you know, the fact that advocacy isn't always necessarily focused on one element. Sometimes it is a multitude of things that need to be addressed. And certainly, I think we can all agree that in the congenital malformations and anomalies, etc., you know, children that are born with these afflictions really often do have a lot of issues with regards to stigma, acceptance, and as a result of that, there's a high incidence of social elements as well that need to be addressed when advocating for these children. So I think it was an absolutely perfect introduction. Thank you so much, Claire. I'm now going to hand over to Miss Esther Masika, who is the founder of Tunu Africa, and Esther is from Kenya. And just an interesting fact, we have the most amount of registrations coming from Kenya for this meeting today. So we are super proud of our team in Kenya. Esther, over to you.
Thank you so much. Jumbo to everyone who's here today. Thank you for joining us. My name is Esther Masika, the founder of Tunu Africa. I am a first-time mother to a wonderful girl called Tunu. How I joined this journey of birth defects prevention, detection, and early treatment is through the birth of my daughter, Tunu, who we discovered at birth to have a congenital anomaly and an unknown rare condition. So I sort of fall in both worlds. And so what we do as Tunu Africa is we advocate for the inclusivity and information dissemination of birth defects prevention, detection, and early treatment. I would say I'm more focused on the parents, the primary caregivers to children who have disabilities and birth defects, especially those who have correctable birth defects. Like, so we deal a lot with clubfoot, and we advocate a lot for clubfoot, and have programs running to support families such as the Bold One Out movement, and I'm a person first campaign. So such a pleasure to be here. I'll just keep it short. You'll hear more of my voice as we go along. Thank you.
Thank you very, very much for that introduction. And it will be really, really nice to get a little bit of the insights with regards to advocating for not necessarily the primary beneficiary, but, for the surrounding caregivers and family members as well, because equally as imperative, when you take into consideration that, dealing with these conditions is not necessarily a centered thing. The impact is impactful to the entire family. So thank you so much for that. And then last but not least, I still don't see Dr. Ayedi on the line. So I am going to move over to our final speaker, who is proudly South African. And I think many of us have had the pleasure of working with her. And that is Ms. Karen Moss. And she is the founder and executive director of an organization called STEPS. And I can tell you STEPS is one of those organizations that we all aim to be a little bit like when we're older and we're big one day. So Karen, if I can, over to you.
Wow, thanks for the lovely introduction, Kelly. I feel the same about your organization. So I think there's so many amazing people working in this space. And I started very much like Esther as a mother of a child born with clubfoot who's 20 years old, and found a far better way of treating him than the complex surgery that was available way back when. Was lucky enough to meet the person who developed that technique, Dr. Ponseti, who treated my son within 3 weeks with no surgery, which completely changed my whole life path, because I asked him, why was this not available in the country? And he said, until you become an advocate those years ago. And it's grown into a deeper understanding. I agreed with one of the first comments that it's networking. I think that's been one of our core keys to good advocacy, was initially partnering with health professionals to try and get this method. It was really making a massive change in the way that clubfoot was treated, with very poor results and lots of children not getting any treatment at all, because so many places they couldn't access surgeons that had the skills to do it. And so it started, I suppose advocacy was and training was one of the first things that we did at STEPS. It then developed into 4 pillars, of which the one started 10 years ago was supporting clinics through the state sector, 38 different clinics around South Africa. And there's a lot of advocacy involved in that as well. We've written parent education materials, we've got posters up, we do community events, we do World Clubfoot Day, we give talks to health workers, and it's really all, clubfoot is although cleft palate and clubfoot have similar incidents, I find there's so many people that still don't know what clubfoot is. And once you explain it to them, it's like a light bulb goes on, and you've now created a new advocate. I gave a talk last week at a youth development center, and it was for Women's Month, which we're celebrating here in South Africa. I got 3 volunteers from people who want to now work with STEPS, and all of them said, we've seen these people walking around, we didn't know what it was. So the power of advocacy, the knowledge, the networking, is something that I've learned through my work with STEPS, and also being part of a bigger group of people who are working with clubfoot has helped to make it stronger. And I think the more that we spread the word, and the more that we network around advocacy, it's not an easy thing to do. It's something that grows organically, and it takes various stakeholders, and we're really educating a greater community of people out there to reduce stigma and to increase awareness that some things are completely treatable, others are preventable, and some may be neither, but can still be, that child's life can be made much more rich because of the awareness that comes around it. And then we go to the big steps where the policymakers start to hear about it. And I think I would just say that we're probably worse off than a lot of other areas if it's resource restricted settings, because there's less access to social media, and people living in rural areas are not going to be on Facebook. So I think a lot of interesting things can come out of Sub-Saharan Africa, of new ways of reaching people through advocacy. And I look forward to meeting everybody online and listening to your ideas and feedback. And I wanted to thank you very much for inviting me here today.
We're very, very grateful to have you. So thanks. So that introduces our panels, and I'm looking forward to really getting into the meaty stuff. So we have some good time to get through some questions. And again, just a reminder to everybody that's listening and in the audience to please submit your questions via the Q&A so that we can actually get them to a point where we are aware of them and we can ask them accordingly. But I have some questions, and I'm just going to kind of bomb around the panelists, if that's okay, and try to facilitate a bit of a discussion around it. I think very, very interestingly, just something that I note in dealing with this particular region in terms of Sub-Saharan Africa is that the resource element is generally, it is a massive thing. I think if you speak to many first world countries who also deal with advocacy on a day-to-day basis, resources don't seem like such a prohibiting factor when you've got them. But when you don't have them, it's like 95% of the battle. And, I think one of the key challenges is obviously trying to find sustainable solutions that are easy to implement. In our setting, that is Africa, we're often dealing with multitude of language barriers. We're dealing with cultural differences. We're dealing with regional and geographic limitations, making our advocacy work that much harder. And I often find when I'm speaking to some of my colleagues from the first world countries and they present a solution and I'm like, that doesn't work in the African setting. And when you start actually explaining to them, why it doesn't work, their eyes are like wide open and they're like, how is it that you managed to get anything done? And we're like, exactly, right? So I think it's really, really interesting because from a regional perspective, we do have additional elements to deal with that I think many other parts of the world don't have. So I wanted to ask, and I think maybe I'll start, if I can, with Claire, with regards to the advocacy campaigns, etc., that you were referring to in terms of obviously the Afri Child Center and all of the work that you're doing with cross-cutting disability, etc. What would you say have been some of the key success factors that have been necessary in terms of really, really getting a good advocacy campaign going around a particular issue? If you had to give like 3 pointers to someone wanting to do something similar in their particular country, what would be the 3 things that you would say these are the focus areas?
One, I'll definitely say evidence. And thank you for that question. Having evidence, the reason a lot of our advocacy efforts are struggling, and we in Uganda are still struggling, is the absence of evidence that you can point to and say, okay, these are the numbers, this is how it's going to affect productivity of the country, this is how it's going to link to the economy, and being able to demonstrate it in a way that the people who make decisions on where funds are allocated can understand. So, for example, some things don't make sense to them unless you say, this is how the economy will be affected. In future, this percentage, this proportion of the population won't be as productive and they won't contribute to the economy. So evidence is, for me, is a core success factor. And so we are, right now, our work is really in the early stages because we are really trying to gather the evidence so that we can make a case for it. So 1 is evidence, 2 is political will, and political will beyond what we talk about every day as political will, but around our relationships, being proactive in building these relationships with the people that matter, the people that have a say. There's one element that we also downplay a lot, which is the element of trust, even as we do our work. I will believe what you say because I trust you. I've gotten to a level of trust. So not everyone that walks into an office gets things done or gets their voice heard. It's building relationships, and that's something that's really hard to budget for, to talk to donors about and say we need to invest in relationships. What does that look like? We don't know. We don't always know what it looks like. It can take different shapes, but being aware of the fact that it's human beings in these positions, it's human beings who ultimately run the systems. It's people with feelings and emotions and all that can make changes that will eventually lead to success in prevention efforts and all. And then the other is really connected to evidence and the relationships, is to communicate science, how we communicate. A lot of what we have, even in evidence, I don't know about the other countries, but in Uganda, a lot of what we have is very technical. It's terminologies that, yeah, you don't understand. You have to Google and all. So being able to communicate science, a lot of it is again still within the health sector, and yet there are multiple intersections to these issues. There are social aspects to these issues. There are experiences of families and what they are going through. So how do we account for this if we don't communicate our science, if we don't communicate what we know? If, say, the doctors, pediatricians don't communicate what they know about these conditions in a language that is easily understandable, so that the people we want to take action can understand them and realize the indication and then take action. So for me, it's really the two critical ones are one, evidence, and then relationships, but then it's also important on how we communicate, how are we proactive. I don't know again about other countries, but for Uganda, the formal health system is really there. It's there, and the people are here, the people that use it and run to it for services. And in many cases, especially with rare diseases, with some of these conditions, people go there as a last resort. If it's not identified at birth and people guided on what to do, they will go there as a last resort after going to the witch doctor, to the pastor, to the preacher. And so understanding the context within which these conditions are happening and how the interpretation of the conditions affects and the perspectives of those around this child or this mother affect what response they take. So for me, that would mean then for us in the research field, and then health workers being more proactive as opposed to waiting for people to eventually come to the health center, to be proactive in creating awareness, raising awareness with mothers, even when they're still pregnant, raising awareness on some of these conditions. So for Uganda broadly, I would say we are still at a very, very early stage with these conversations. And even before we talk of advocacy and we need to get these people to appreciate and be aware of these conditions. What are they? How are they affecting people? What is the indication of what families and children are going through on the country as a whole? Thank you.
Yep. Absolutely. Thanks so much, Claire. Really, really interesting stuff. And I think really, really striking a point. And particularly around the need for that evidence base, and that you're actually needing some form of a scientific argument to be able to advocate around, to be able to get any traction. Karen, if I can come back to you, because I know that this is one area that you've been really successful in terms of actually getting that evidence base and being able to shift a change, from very, very few patients receiving the intervention, in using the evidence base, being able to show that, the solution is viable, sustainable, and has great outcomes, to be able to getting so many patients treated using that method. How would you encourage anybody that's listening that is looking into this advocacy kind of space? What would be the key pointers in terms of developing that evidence base and actually utilizing it to further their advocacy?
I think the first step we did was to find our champions, because you can't do it alone. And I'm not a doctor, I'm a parent. I had to find doctors that were open to my suggestions and wanted to start trying the method. Also brought international doctors over to convince them. We developed a consensus around it, and then started to partner with, as I believe, agree with Claire on the evidence base, because we partnered with all the academic hospitals and heads of departments, so that it was starting to move into a public health issue rather than just a clubfoot issue. And how was this impacting? And then the massive hurdle was the fact that in South Africa, the collection of birth defects data was pretty much non-existent. It had moved over from paper to digital. In fact, call, and she's an expert on this, but it was dire. There was no way for us to even know what was going on in the clinics. So we developed our own system of collecting stats from the clinics. And because of the Protection of Personal Information Act, that was also hindrances around that. So we had to do anonymized stats, and we developed a system where we started to collect simple stats from clinics. How many children were admitted for treatment? How many patients were there? Clubfoot also has a high incidence of recurrence because patients are lost to follow-up. And the initial part of this treatment is 6 to 8 weeks of serial casts, and people can't afford the transport to get to the clinic. It's a massive social problem. It's not only a health problem, health becomes an economic problem for these parents. And from that, we started to develop a very clear national picture of what was going on. And we've started on, I think, about 200 odd patients. We're now over 1,000 that we're getting stats on. And that's new enrollment. So there's over 4,000 that are going for treatment. How we got there was a lot of hit and miss because there was nothing out there that worked for us. As you were saying with them, I don't want to, trash other people in other countries, but we're living in a different reality here and what's available. And they'd say, well, all you've got to do is have this. And I say, well, we don't have Wi-Fi in the hospitals. So we've got a real-time data collection. We've got patient confidentiality. We can't do that either. So it was a long process of collecting those statistics, which has now led us to the point where we've been we've now got this nice chunk of evidence-based collection of data that we've got from all these clinics. What's the cost of this? What is it actually costing the caregivers and the government, because it's working through their sector, and what's it their facilities, and what's it costing STEPS as a support organization? And then taking that a step further, and what is the cost of a child being permanently disabled versus a child who's treated successfully for clubfoot? What's the impact on the economy? And I believe that these kind of things, if we look at advocacy from all, I think someone, I don't remember who it was, mentioned it, there's so many, it might have been you, Kelly, there's so many different aspects to advocacy. We can't work in silos and only see our perspective of it. There are so many other allies that you may not have thought of that are also all the different stakeholders involved in the well-being of a child, and the economy and so many other things. And it's kind of thinking big, and don't be scared to think big, because it really does help. And I think collaborating and sharing as much as you can with other organizations only makes you stronger. And I think that's where we've landed up where we are today. And there's still a lot more to be done. But yeah, hindsight is always 2020. There's certain things I would have done differently if I'd known at the time, what the challenges were. But you do definitely learn from those failures. And we've now developed something that's also suited to our local condition. And I think that's important, because everywhere we are, it's going to be different needs, different cultural beliefs, different systems available. There's no one size fits all for this, although the message may be the same. The implementation is going to be different. So I don't know if that's answered your question.
100% it has. Thank you so much, Karen. I think, obviously you raise a very, very important point, that patient influence in terms of solution design is such an imperative thing. We shouldn't be trying to develop solutions without actually speaking to the patients to see if they work, and they work for us. And certainly we need to lead interventions that work in our respective areas, and the best people to do that is us. So this is why collective advocacy is so important. Esther, if I can come over to you, because I think obviously from a parent perspective as well, and I can only speak from my experience as a rare disease mom myself, the need and how you can harness social media essentially, and how that has significantly closed the information gap. What sort of key pointers do you have in terms of using the information that is available there to lead this evidence base that Karen was speaking about, because that is an alternative way. That's how we strengthen our lay expertise as patients, is from those experiences of the people that you connect with online, but also how you can use those platforms to really, really strengthen your advocacy.
Thank you for that question. Yeah, I mean, when I will just, of course, share my journey, because the first thing when I found out that my child had been born with a congenital anomaly, I was just like, what is that? And then, and then the doctors were there, and like, Claire has rightfully said, the information is broken down in a very medical way. So you don't really follow through what they're trying to say. So you'll just hear, I'll just speak about clubfoot. It's, why does the word escape me? But something equinovorous. Maybe Karen can help me out there. There's a scientific word for clubfoot.
Bilateral talipes equinovarus. That's what they told me my son had. I'm like, what?
You can imagine.
Yeah.
So you've just given birth. You weren't expecting anything to be wrong with the child. And I think Dr. Jakob here mentioned, it's really important where the preconception education comes in, because during my whole antenatal journey, there was nothing that I was warned about in terms of birth defects prevention and things like that. It's just one of those things that you're found to be pregnant, and it's at that point that they begin, with you taking your supplements and things like this. But along the journey, you do discover that, if you were planning for a pregnancy, that you should have begun maybe being on folic 6 months prior or a year prior. And now this thing is almost like it's age related now, depending on how old you are and things like that. So you find that is not information that I had as a first-time mother. And I really do speak here like as a first-time mom, because we go by the experiences of those who have gone before us. So we kind of tend to follow their journey, and we rely a lot on what it is that the doctor is saying. So you hardly find a lot of first-time moms going into lots of research, like what is birth defects? You don't want to doom yourself and things like that. So you sort of go by the journey. And it got me to where I had gotten. The doctors themselves, when they met the baby, I think how they broke the news to me was shocking for them and for me. And from there, I tend to think the first step for advocacy is really acceptance, because it took me a minute there to accept the reality that I had, because the child that I now have before me is not what I was expecting. And so it took me a minute there to accept that this is the reality of what it is. You obviously go online to look for information on what it is that, what options are there to help your child. And you find that the information is very limited or very scanty. There's no one place that you can go and just, find the information that you need in regards to your child. But what did help actually was those support groups that you find online. Now, the challenge with that is most of the support groups that I was getting, you find they were in the States, in the UK, and I'm like, oh my goodness, I'm alone in Kenya with this problem. Nobody seems to know what this is. So I would take a lot of photographs, send to people, and I'm like, this is how the child looks, which was traumatizing for me, because, that's not how I wanted to begin my motherhood journey, in terms of turning myself into a medical doctor. All of us, you've just become a mom, and then you've just become a medical doctor, because, all these terms are being thrown at you. And there's also the thing of trying to move forward when you've been told, there seems to be an issue with the child, but they can't really identify what it is. So you don't really know what you're working with here. But the photos did help. And I did get a late diagnosis on it, in as far as the rare condition was concerned, which was arthrogryposis. And you find that there are very few cases here in Kenya, and it affected the way the clubfoot treatment for the child was being done. As Karen has spoken about, the Ponseti method, that is, the most adopted method in most countries. You find, because of the condition my daughter has, which is arthrogryposis, it puts the clubfoot treatment in a totally different scale, because it's now syndromic. It's as a result of a condition. And so Ponseti was not really working well. And while I was using my daughter's story to encourage other moms, like, hey, we can do this, we can do this. It's a correctable disability. Let's, I think in that space, I was like, let me try and do my best to encourage other moms, because clubfoot is correctable. They don't have to enter the disability bracket. There's something that is actually available for them, this treatment that is available for them. But as I journeyed on, there were so many relapses with my daughter that I stopped documenting how her journey is progressing, because I was like, hold up, there's an issue here. Why is the relapse so much? And, you know, they'll still be told about Ponseti, but it takes a persistent caregiver to be like, no, we've been here before. You know, challenging doctors is not easy, but it reached a point where I had to, because I was like, no, I've done this, and you're just being referred to several doctors. So there's no one point where you have all these doctors in a room that then you can now create a treatment plan for your child. So every doctor has their own opinion and everything. So for a caregiver, you really are scattered in as far as what is the right direction to take. And that is what has got me to platforms like this, you know, collaborating with Karen all the way in SA, because, you know, I'm vocal about what it is that I do. So there's no one solution fits all sort of a thing with some of these conditions. And so I do feel, yes, online, the information is available to us, but it needs to be broken down to a level that it can benefit the caregivers of these children, because if they don't show up, then the child, unfortunately, you know, ends up either going into a lifelong disability and things like that. The other challenge I would say is that in some of the countries, like where clubfoot is concerned in Kenya, you know, it almost felt like there was nothing that could be done locally, but you do find there were many clubfoot clinics. So like Karen said, the challenge was not that there was no help available. It was that whole thing of the lack of awareness of it being available. Yeah. And the fact that in itself, getting to that clinic, especially where clubfoot is concerned, it's an 8-week process. So you find for many families, they're just like, oh, wow, do I take the child to hospital? Do I buy my family a meal? Sort of a thing. Yeah. So you find parents being in that sort of a situation, and having to choose between a meal and a child, you know, is a very difficult thing to do. But, you know, you add up your math and you just find that, you know, they'll start the clubfoot clinic, but not many will actually complete the process. Is just sort of give up in between. So it is important that they receive their support where necessary, especially where transport is concerned, where diapers are concerned. Also working with organizations, like Claire said, it's not just, you can't look at this issue one way. If I was a working mom at the time, I'm wondering how many times would I have to ask my employer for an off on that day because I have to take my child to hospital. So there are very many aspects that we need to include in this conversation. Thank you. 100%.
And it leads me to a comment that's come through from Christine Matena, who I'm sure you know, from Rare Diseases Kenya, so from your neck of the woods. But Christine was saying there's also a point where the healthcare providers don't tell you the extent to which your child's condition and what to expect later in life. You told your child has A, B, and C, and then are discharged, and parents and caregivers have to literally learn on the go. I think that that's essentially what you've said. Like, you know, you don't necessarily have a place to go to, and you're finding out as the you know, the issues hit you and you're trying to dodge them.
Yeah, absolutely. And at no point did they take information in terms of birth defect surveillance where it's concerned. At no one point was I in the hospital and they're like, oh, we need to, you know, add this information. You know, I never got the sense that they counted me as one of the people, and they never followed up to see where it is that I am. So psychosocial support also is needed when, you know, you begin this journey. So I think there are missed opportunities out there where healthcare facilities are concerned, and it's time that, you know, they are also educated on the need to gather this evidence.
Absolutely. If I can, Dr. Ahmed, I'm going to ask you a question, kind of tying back into what we're discussing at the moment, but with regards to your thoughts and your advocacy process with regards to fortification and stuff, which is obviously largely a preventative measure. You know, I think very, very often as parents, particularly with congenital defects, when your children are born with these conditions, the first thing that takes place as a parent is this overwhelming feeling of guilt. And a lot of the time, I think finding out that there are things that could have been done to prevent it is equally as difficult to learn later on, because it almost is like it's a double blow, because you're like, oh, well, had someone actually told me that prior, or had I known you know, the importance of folic acid, the reason that they encourage you to take it, etc. Had I been to a proper clinic, a pregnancy clinic at the time, you know, those things might have improved. So it's very, very difficult, I think, to highlight prevention, but in a way that's sensitive, that you don't disarm parents who might already be on the other side of the fence. Do you have any sort of comments or questions? And I know it's quite a complex question, and I'm asking it because I think it is so complex. So, you know, take a stab at it if you wouldn't mind.
Yeah, okay, thank you very much. I think every concepts are really interconnected. What Claire say, all of them say, like one idea support the other, I can say. But specifically to your question, so there is prevention, there is treatment, and there is after treatment care, because it's like a lifelong care. So it's not easy, especially in my country. I can say that work for most of African country as well. Birth defects sometimes are labeled as a curse, and it was associated with also the mother as well. So it was really, it makes it very difficult, not only like the case, even the mom accept the issue, the community stigma, discrimination, and also attachment of the issue to mom's mistake. They call it like, oh, this is because of you. And then we have, in our follow-up clinic, we have more than 4,600 children in our 8 hospitals. And we have some like preliminary assessment, and many of the mom get single after they have a child with this defect. So this means like a very difficult one. So one thing I can add from the previous conversation is, you know, the information is very powerful. Knowledge is very important. It's not only in the individual and the community, and even in the healthcare industry. I've been in healthcare as a professional and in the healthcare for years. So birth defects are not really well known, even in the healthcare professionals, not only in the community. So one is providing appropriate information in a continuous manner in all available channels so that people get awareness about this problem. They have to know that this is a preventable problem. This can have an options of treatment, and children with birth defect can live a life, like improve. This information, I just can't understand it more, but it's very important, which I learned from this journey. One. The second one I can mention is stories. Personal stories are very powerful when it comes to birth defects. So if you have a baby with cleft foot, or if you have a baby with spina bifida, if, for example, we as Reach Another Foundation, we focus on creating access as near to us possible. So we work with 8 hospitals throughout the country because we want to show the community this problem is treatable. So a child with spina bifida can be treated, and he or she can really work. For example, we have a staffs, and one of our staff is a physician. He himself has a spina bifida. So that's like a success story. So family should see that their children can grow, that their children can be as healthy as they can go to school, and that's one thing I can underline. So personal story, success stories are powerful than the scientific evidences, research findings, all those things. I know it's very important, the other side, but personal story. The second very important and is really demanding one is advocating for multidisciplinary care. So we have our assessment, one of the dropout for treatment, one of like cause of mortality is, okay, you bring your child today for neurosurgery follow-up, and the neurosurgeon say, hey guys, I did my evaluation, you need to see orthopedician, you need to see physiotherapist, so this mom should like come back and forth to hospital literally every single day to find out every single specialist, right? That is a very difficult in terms of cost, in terms of time, in terms of psychosocial issue. So the other thing that we tested is we work with this 8 hospital, show up a multidisciplinary approach of care. So a week ago, I was at Mombasa, Kenya, to share my experience at Coast Hospital in Kenya, how they can come up with like a multidisciplinary clinic. So that's a very important aspect. So a mom should come to the hospital today, and let's try to make at least all available. I know there is a limited resource. You know, we are living in a very disparate situation in Africa, but at least available resource can come to one clinic and the mom can get multidisciplinary care. This one is the second thing that I want to mention. The third and the last part is support groups are very important. There are privileged mom like, Esther, she can be in a computer, she can have access to internet, she can jump into global, support group. Most of the moms with a baby with birth defect, even though they doesn't have cell phone, leave alone internet support group, they are not educated, economically disadvantaged. So this mom needs a very local group of people who have the same problem that can share ideas, they can build their emotions. So advocating a local support group, community support group is very, very crucial. So we work with mother support group and in the city, and that's where mom come together. They cook breakfast with their children, discuss about this birth defect issue, as you said, the prevention option, at the same time how we can live with it and how we can improve the quality of life for our children. So in addition to what Claire and what Esther says, I can again underline knowledge is very important. Let's keep on teaching people in all arena. Let's have a very powerful stories of individuals who went through the treatment program, have a successful life. That's really powerful. And let's advocate, as I said, let us advocate for multidisciplinary care so that we can minimize the cost in every aspect of the care provision process. And the last one is, the mother support group. I can say community support group is much powerful than the care we are providing at the hospital level, right? So they really share an idea. The child live with them. They are their child. They know the needs, the symptoms, the signs, what he shows when we have a wet bladder, or when we have, a wet diaper. So this all cannot be really easily picked by professional. As Esther clearly said, the professional will not be as comprehensive as a mom wants. So that's where it comes. So I can underline these 4 additional strategies, to come up with a very good advocacy message, and at the same time influence the policymaker, influence community influencers, and as well as even influence, some of powerful professionals like neurosurgeons in the hospital. They can be part of this movement, and they are heard easily. They have power because there are very limited people in one hospital. They can create a huge difference. But all is all about the babies. I can say all about the all center of our intervention should be the babies. Then when we do that, I think our advocacy can be effective. That's what I have learned through the process the past couple of years.
Thank you very, very much. Really, really interesting stuff. And I want to ask you all a question. I'm going to ask you to name one thing and what you're doing to address it, but you're not allowed to mention resources. So the question is, what remains the biggest advocacy challenge that you have within your respective areas? And I'm going to ask you all to answer the same question, but resources can't be the answer. And what are you doing? What's your big goal in terms of actually trying to tackle that issue? And I'm going to start with Claire.
Thank you. I don't know why I'm frozen. Can you hear me?
Yeah, we can hear you, but you are frozen.
Me?
We can see you, but you're very still.
I don't know why I'm frozen. It's been puzzling me, but thank you for the question. You said we can't say resources?
Yes. Resources.
Okay, really, it's getting the attention of who matters in getting those, in getting the right allocations, okay, for our government, allocating the right resources and really taking action. Even using the little evidence. I know there's some work that's been done in 4 hospitals by a great team that's part of the SCAN network. So taking that evidence and beginning to, so in terms of what we are doing, or what the goal is, would be to get, to go for the low-hanging fruits. What is happening in other countries? There's a lot of evidence on fortification. So can we work towards getting a pronouncement on fortified foods, like low-hanging fruits? We already have the evidence available. It's overwhelming. The science speaks. So even as we wait to, get our locally generated evidence, there's already evidence that, food fortification could do a lot in preventing birth defects. So using what we have, starting where we are and using what we have. So I'll quickly touch on a few, but all leading up to the same thing, getting the attention or getting some kind of action from government and from the other stakeholders, including people that are funding different pieces of work, people that are doing child well-being work. You don't have to be working on club food to cause change towards club food, right? So adopting that holistic and multi-sectoral approach to what we are doing as practitioners, as researchers and all. And I'm very comfortable speaking about research. What is the goal? What do I see as being promising in the field of even when we have limited resources? One is, again, start with what we have. We recently concluded a study. It was exploratory. It was a really small study, but it can get a conversation started. A sample of about, we came across 51 children in refugee context, but it can get a conversation started around the needs of children with developmental disabilities. So going for the low-hanging fruits, what is the evidence that is already there, even without us generating it, advocating for a pronouncement on something that's really easy. It's easy to enforce the fortification of foods. The other thing is, in another field, we are working towards a registry, a social protection registry. So borrowing from that, how hard is it to at least start with hospitals? Because every birth is registered. So can we start in hospitals and have a registry? That's one way of using evidence. Even as we wait for big grants to come for research, we can use administrative data collected in hospitals to make a case and say, look here, these are the numbers, these are the conditions that are common. This is what we know from science that can lead to prevention of these conditions. So really, what do we have? It's looking at the resources we have. I don't want to think we don't have anything. We do have resources, even if it's research already done in South Africa, even if it's what Karen's team has already done, or the team that's doing work in 4 hospitals. It can start a conversation and ultimately lead to action. Thank you.
Really interesting. Thanks very much, Claire. Karen, I'm going to move to you. Same question. No resources can't be the answer. What is your biggest challenge and advocacy challenge, and how are you trying to overcome it?
Well, I don't know if funding counts as resources, but
it does.
Well, I think it's kind of, for us as a small organization, how do we reach the whole nation to share this message? I think that's the biggest challenge, because we only have a certain audience, and usually it's people who know people born with clubfoot, or they've heard about it, and how do you reach the man in the street, and how do you get that message through to the mothers that it's not your fault, that if she's living in a rural village in the Eastern Cape? That is a massive problem, and we haven't solved it. But what we have tried to do is to create more accessible support by decentralizing treatment, so that it's not only in main centers. We support people who want, through trainings, we identify new people who want to open clinics. We then, once that clinic's open in a smaller, and I agree with what Dr. Ahmed was saying, you bring the treatment closer to the child. That is such a huge part of especially birth conditions, is not having to travel 500 kilometers to get to a clinic is a massive difference. And from there, we then able to advocate in those smaller clinics. We may not be reaching the whole community, but we have trained the local health workers on clubfoot, how to identify it, how to treat it. And the families the babies that are be born there are getting diagnosed. And for us, that's like a ground up approach in how to actually get to the greater community, because how else do you do it? We're not the New York Times, we're not, DSTV. It's to get that whole audience. So we just decided, let's bring the treatment as much as we can decentralized, supporting health professionals where we can with training and clinic support because it's a very brutal sector to work in. Most people don't want to work in rural areas. It's tough, but when they do, they really need your your cheerleading and as much as you can do to help them, and then bring all the materials in that we've developed, advocacy materials, and that's worked well. And it's like anything, word of mouth. One person hears about it, the next person in the village, and the fact that I think is nice for Clubfoot. I agreed with what Dr. Ahmed was saying about having in-person support groups. I think if you're talking about the more rural, sparsely populated big areas, not always easy to do that. But a Clubfoot clinic is run weekly. So you have children of all different ages in that clinic. So you'll have a newborn parent meeting a 3-year-old parent, and I had the same experience in Iowa. Arrived the first time in Dr. Ponsetti's rooms, and he immediately introduced me to a family with a 3-year-old and showed me pictures of his feet. That's advocacy, the parents talking to each other. So that has been our solution to trying to get the reach out to people.
Really, really good. Really, really good answer. Thanks, Karen. Esther?
I wanted to turn my computer off, but
come on, you'll have something good.
I think I'm going to be a bit controversial on my response. I think as advocates, what we tend to do is really focus on the issue, on the defect. But there are other aspects that are surrounding this child that the parent is curious to know. Like, we need to send a message of hope, so it really, really needs a lot of courage coming in from the parent, but putting out, positive advocacy. That is what I'm going to say, because there definitely existing needs and evolving needs of this parent. But, when you listen to a lot of advocates speaking out there, it's really a message of doom, like, we're never going to get out of this. It's not working. Systems are not working in the countries. Even if I was to take my child from here to a different country, it's like there's also one or the other issue in as far as accessibility is concerned in that country. So I believe there are other aspects that surround this child. And so we have to be careful as advocates to look at advocacy holistically. And I speak this because just because my child has a physical disability, they're not affected in their mind. They can learn, but you don't find that coming out very naturally when you're advocating. You tend to focus on what's not working and the things that you really can't fix. But there are other issues that are ongoing that you can count them as, milestones for your child, so that these families feel, all right, so not all is in vain, that they need to change the lens in which they look at their child as somebody who in society can become someone, as somebody who can contribute to healthcare or whatever other industry that exists out there. So for me, I think the challenge is to really get out of this space where we are so focused on Clubfoot. My child is going to school and initially had to be carried and everything, but she's going to school nonetheless, despite or in spite of this condition. So her life is still moving around her. And that's the picture that we don't get to see every day. Karen has really motivated me. The son is 20, my daughter is 3. So you can imagine, I need to, after this, be like, okay, at 3 years old. And when it comes to advocacy and what Dr. Jacob said is, it's important. Yes, the parent support groups are important because Karen has gone ahead of me in this journey. And so I'm able to be like, is this normal? Because the resources that are available to us online are for a typical child. So you find for children who have been born with rare conditions and birth defects, it doesn't quite follow those at 2 years your child should be doing this, at 3 years your child should be doing this. For us, it doesn't follow, not all things follow that pattern. So it's important for Karen to be there to let me know, oh my gosh, yes, I passed through that. You only wore your brace yesterday. You threw away the brace. Oh, that's fantastic. Even me, I used to throw away the brace, and it sort of encourages me that it's not that I've given up on my child, but yes, the bad days will be there. but the good days are also there. And she's the light at the end of the tunnel because her child is there at 20 and is doing these amazing things. And so I see my child's future using just by her story, by observing her, by talking to her. Also for advocacy, I would say, yes, it's important to meet as groups, but what I've learned in the little advocacy I have been doing here, it is really difficult for people to turn up for those kind of meetups. They just prefer, you know, the WhatsApp calls and talking to you one-on-one on a one-on-one basis than as a group, because they just almost feel like, no, this will be too overwhelming for me. But on where one-on-one is concerned, that is where they feel more comfortable until it gets to a point where you turn them into advocates and ambassadors that they can actually get out there. And so let's not, I mean, so it's some of this advocacy efforts of mine, I would say, have backfired because you call for people to gather and they don't, because they're like, oh, no, I'm not going to come there so that everybody can know I'm a clubfoot mom. No, thank you. I'll just call you where I have an issue, Esther. And that's that. And I guess that's where social media comes in, because then we're able to have forums like this that people can watch at the comfort of their homes and still get the knowledge in. And, you know, we prepare them to make, you know, the next informed decisions regarding their children.
Oh, 100%, really, words of wisdom. And I see Christine's made a thing here saying positive advocacy, and that's exactly right. Dr. Ahmed.
So I think I will not going to repeat what others said, because as you know, that is a shared idea. But I want to point out some critical challenge when it comes to like advocacy in our work, and also in my, I had this health policy fellowship at Emory, and I did one paper was birth defect professor in Emory. And one of the issues I try to see is, what did the global advocacy look like in terms of, you know, birth defect? So one of the challenge I came up with during that assessment is, where should we focus? I don't know how I can put this. Where should focus? You know, there is a critical gap, as we said earlier, in creating access to treatment on the ground. And there is a critical gap in terms of awareness about this issue. And also there's a critical gap in terms of the policy, the political will, like including the birth defect piece as part of the health program, as part of the, so, you know, which, you know, what proportion of our resource, what proportion of our time should go where? That's you know, we don't have really, like, for example, in my organization, we really value the children, and we want to put most of our money on the creating access to the treatment to the children. So, and then in meantime, we're not really actively pushing the policy people to put this as a health program and a policy. So that's one challenge I saw in the process. The second one, I don't know how this, we were not really loud and clear. I have to be loud and clear. Money is very important. If there is no money, no mission sometimes. When it comes to resource limited setup in Africa, there's a competing priority. So if you want to open up a nearby clinic, like spend up a clinic, at least you need to set up the clinic. It will cost X amount of money. There should be a thought. So why I am mentioning this one, if there is no money, if there is no mission, so funding organizations should see birth defect is one element for, you know, to be funded. You know, they've been putting a lot of money in many, you know, and sometimes there is like, you can feel, oh, how the world really thinks this public health problem. You put millions of dollars in X program, if you see that program contribution toward the child mortality, or if toward this, you know, economic development, it's important, but really the birth defect aspect is on words like investing. So how many of us can really name 1, 2, 3 big funding organization, philanthropic organization that are interested in funding actually this program? Sometimes you may say none. Sometimes you may mention 1, 2, 3 in a very small scale. So many is very important. I can say in this one. So that's another challenge that's coming in. And a third one, a third very important challenge is, you know, countries are influenced by sometimes a global resolution, global program. So, you know, the face of the global health, like WHO, UNICEF, where they're advocating for child health, child rights. So this birth defect is part of the bigger challenge that kills children. For example, there is one study in Ethiopia going on with CHAMS, Child Health Mortality Surveillance Program, led by London School of Tropical Hygiene. And that preliminary finding shows that birth defect contributes 10% of children mortality in one region of the country. So this is like a huge number. It's a huge number. So this deserves like funding. So that part, the advocacy at large scale, I call it macro advocacy. So we advocate at national level, we advocate at facility, local, community level, but there should be a macro advocacy, like at the WHO level, at UNICEF level, that they have to put that as a priority for child mortality, neonatal mortality, child inclusion, and that part is missed. Why I'm saying this one is, I can give you one story. Last year, we initiated with G4 Alliance and GASPI. I don't know whether you know them. So we advocated for the development and the approval of a resolution, multivitamin, yeah, it at WHO for. So I was there in May to attend with WHO. I was a panelist to convince the policymaker how it's important that the WHO should approve the resolution that mandate member states to add folic acid and other micronutrients at one of a stable food in the country. It can be oil, it can be salt, it can be, so that advocacy problem was, that advocacy journey was a very good example. If you bring global public health people, if you bring global influential technical people like neurosurgeons, surgeons, can really influence a big funder, a big policy maker like WHO, UNICEF. So I can call it, we have to give a little time for a macro advocacy, like a macro level, beyond the national level, because the national health programs are really tailored to the global health program sometimes. So that one is one thing. The last part is, showing, sometimes people don't understand some of the treatments are easy. Like, it doesn't, sometimes like when you talk with hospital director, for example, my routine work, going to hospital and talk with hospital CEO, they feel that like establishing a birth defect, like spina bifida clinic or clubfoot clinic, they feel it's too expensive. Yeah. So when it comes to resource, I want to say like this team, we have to be clear in what resources needed, how much it costs. Yeah. Sometimes there is an idea of like, oh, a spina bifida closure or VP shunt insertion, maybe a very simple neurosurgical care. It's a part of neurosurgery. And when you mention about this one, so the CEO say, oh, this is so expensive, I don't have budget. Hey, come on, it don't need like a very big resource. It needs this. So be simplified. We have to try to simplify the resource that needed for the case. So these are some of the additions that I want to make from Claire, Esther, all of them made a very great point in terms of, challenging advocates. Yeah, thank you.
Thank you very, very much, Dr. Ahmed, for stressing the points of reprioritization of funds, I think. So there has been a question that's come through on the Q&A with regards to stigma, and we are running out of time. We've only got 10 minutes left, and I want to keep some time for closing comments, but maybe I can ask I want to say the two moms, being Esther and Karen, with regards to what is it, as stigma, and the reason I'm asking you specifically is because obviously it's had a personal impact. When it's your child and you absolutely desperate for acceptance in the world for anyone's child, there's nothing worse than hearing your child doesn't quite fit in. What can we do in terms of advocacy, particularly when it comes to stigma? And we obviously understand that in the African culture, there's a variety, stigma isn't just, there's obviously this culture, the cultural beliefs and stuff as well, that almost double the impact of stigma within our setting. If you can just give quick summaries in terms of what you think can be done around that. I'm going to start, Karen.
I did experience feelings of shame and worry and all kinds of things, and even my family were, it's no one knows what to say to you. And I've come across families living in the Western Cape who got farms and well-off people that have hidden their children away because they're embarrassed that there's something wrong with their child. I think the first thing that we tell any mother, and this is different possibly to other, like, for example, when you can take supplements, there's nothing you can really do to prevent clubfoot. It just happens. So we try and make it very, the incidence is more, is still not known. It's idiopathic in most cases, it's not linked to anything. So the first message we tell mothers and their partners is not the mother's fault, because it tends to be the mother who gets blamed when there's something wrong with the child. It's not the father. The father seems to get away scot-free most of the time. And then to normalize it as much as possible, create that warmth and supportive community around them is so important. And not to make them feel like they're different, because I remember taking my son in for some kind of immunization, and he was in casts, and I was so like, I was trying to hide them, like people are going to think I've broken his legs, or, it just looked so weird. And this nurse said to me, just don't worry about it. That little boy over there has got an undescended testicle. That one's got asthma. That one's got eczema. There's no such thing as a perfect child. They've all born with their little things, and don't worry about it. Yours is just more visible. And that was a huge sense of relief for me. So I think coming from a perspective as a mother, I'm going to wrap it up fast because time's running out. I know I really highly identify with every mother goes through. And I think getting rid of cultural stigma, that's curses from ancestors, clear information and success stories of what is clubfoot. It's treatable. We share a lot of graduation stories. This child was born with this, they're now fine, and that's, you just keep on pushing that message across until eventually it just becomes part of your normal ecosystem. A child's born for clubfoot, they get treatment, and we all move on. So we're still a long way from that, but that's the goal.
Yeah, absolutely. Thanks very much, Claire. And Esther? Oh, sorry, Karen. Claire, talking to Esther. Sorry, Esther.
And I support exactly what Karen has said. I think it's that thing of letting everybody know that you are not alone, because stigma, you tend to feel like you're by yourself, you sort of close yourself in. But I think the sending out messages that you are not alone is important. I know what worked very well for me, and which is my point, is the caregiver education. I did do a course on caregiving. I didn't even understand I was a caregiver. I didn't even understand I was grieving, the loss of my child. I was trying to be this superhuman mom, super mom and everything, but deep down I was grieving. So, just allowing myself to go through the emotions and to understand what is going on with the child, so that I come into reality and step into my role as the mother. Yes, the things I cannot do, I'm not a doctor and all these things, but as a mom, I have the responsibility to love the child. I think stigma can be, it can be addressed in very many different ways, because as a mom, I can decide if I don't accept my child, then I've stigmatized myself, or I just decide, nobody can know about this child. It tends to begin from home. And then now you think the whole world is against you. So I do think that there needs to be some sort of process that is introduced, like in hospitals, because that's the first touch point for most moms, and how you are received and how you are told those news, I think will impact that child's journey greatly, and it will impact how the parents or the caregivers show up for that child greatly. So I vouch for the caregiver education where matters of dealing with stigma are concerned, because they take you step by step in terms of dealing with this journey.
Okay. Good stuff. Thank you very, very much. Really, really interesting. So we're into the last 5 minutes of this really, really fruitful and interesting discussion, and I've really, really enjoyed facilitating today. If I can, I'm going to give everyone 1 minute for a closing comment. So Dr. Jacob, I'll start with you.
Well, thank you very much for the opportunity. I think this is a very, open and vibrant discussion in terms of addressing this specific problem, and especially in resource limiting setup. By the way, when you guys talk about stigma, I think we don't mention one very important point, which is engagement of community leaders, religious institutions. Now it is very critical. So I really don't come across with a very clear messaging, clear advocacy resource for religious institution, for community leader, because they are the one who can really easily change and influence a community. So that can be discussed in further in other time and investigated, but that has to be, I have seen that's very important. But as a closing, so I can say in Africa, there is one critical problem. It was really well mentioned by Claire at the beginning, evidence. So everyone asks you number when you talk about funding, when you talk about program change, when you talk about policy legislation change, how many children, how much it costs, how it takes. All those questions are not really well answered. So advocating toward this national birth defect registry should be a priority, a year or a time to come. So that's my closing message. We are advocating here to have one national birth defect, but not yet successful. And it should be collective advocacy through available regional organizations like Africa CDC, Africa AU, whatsoever kind of institution. So that's my closing message.
Thank you very much. Claire?
Thank you very much. I must say I've enjoyed this discussion, this webinar. So I want to reflect on to close by reflecting on two realities that we live in. There's probably three, but I'll focus on two. One is we as Africans are a collective. There's that collective, the sense of collectiveness. Ubuntu, I am because you are. And I feel that's an opportunity for us to bring everyone along this journey. You'll notice that a lot of the advocacy efforts are done by small organizations run by people who have first-hand experience with these conditions. That's cool. But who else can we bring along? Like being able to map who else in the bigger family, the extended family, who else can we bring along so that we are many people speaking with one voice and hopefully trying to get action. So if we have awareness, for example, in a single family with the many relatives, then you'll have more people that appreciate this condition, more people that are able to contribute to the voice that advocacy requires. So that's the first reality. The other reality is on, unfortunately, we live in a world of big numbers. In my other work, I work on sexual violence, and in many studies, big studies, you'll have 70% respondents went through physical violence, and then 20% went through sexual violence, and it's not taken as seriously because it's just 20%. But guess what? One case is bad enough. Like one case, so in the same way, one case of clubfoot is one case too many. So if we could then step back and look at experiences, look at emotions of parents, look at, they should count, they should be able to count as evidence of what people are going through so that we are able to get action. Because if you look at a study, the study in Uganda said, I think, prevalence was around 66 births out of 1,000. It may not look so big to a policymaker who is interested in big numbers and high impact, but those are 66 families that are impacted, 66 communities that are impacted. So being able to make a conversation around what we have so that the reality can get to those who really need it. So my closing remarks are really where we go. A lot of our advocacy is going to be successful depending on where we go and who else we bring along, including finding champions in those spaces that can relate with the issues. Thank you.
Thank you so much. Esther, very, very briefly, if you can, please. Sorry to rush you, but we are out of time officially.
Not a problem. I think for me, prevention is better than cure. So of the narrative that we need to begin to send out more, create more awareness on preconception education so that some of this, we can reduce the number of children who are being born with disabilities, especially where it can be avoided. And secondly, it's to stick to the narrative that the problem is not the child who's been born with the birth defect or the rare condition. The problem is the world. We need to shift focus and get the world to really do what it can to accept us as members of this society. You can't expect affected families to be fighting this and also fighting with the world. I think as a world, we need to be a bit more kinder towards the affected families and children, and have a common goal of ensuring that this child lives an independent and an independent life and thrives in today's society. Let's lend our voices out there for this cause.
Thank you so much, Esther. Karen?
Yeah, I think we're fighting for the rights of children born with various conditions, and they deserve every single opportunity that every other child gets within their scope. And I think the more that we use advocacy, it's a very powerful weapon that people don't actually know about these conditions. They may not even understand anything about them. A lot of this comes from ignorance. And by creating more advocacy campaigns, we're bringing more allies on board, we're reducing the stigma, and we're giving that child that we never forget, and that's always our core and steps, that child with clubfoot deserves the best of everything. And that's what we're fighting for with advocacy. And then it just leads on to that, to government, to everyone getting on board. And yeah, it's a big dream, but I believe that working together and networking using the spirit of Ubuntu and kindness, we can certainly make an impact.
Yeah, absolutely. Well, I just want to say from my side, thank you so very much. It's been such an honor to have the opportunity to facilitate today's discussion. Thanks to our incredible speakers for being vulnerable, for the moms and the family members, for sharing their expertise, for sharing what has worked and what hasn't, and generally just for encouraging those that might have listened today who are at the start of their advocacy journey and are really looking to strengthen our collective advocacy systems across Africa. So a big thank you. Also a big thank you to the Global Health Network and obviously SCAN for allowing us the opportunity to bring this webinar to you. Just a note that this meeting has been recorded and it will be available on the Global Health Network YouTube channel. So I encourage anyone who wants to share it with people who might not have been there today to visit that YouTube channel and go and do exactly that. And also there is a link in the chat specifically for a follow-up survey, just so that we can get feedback on how everyone has found today's meeting. But lastly, a big thanks to everybody. Thanks so much for the opportunity, and really look forward to having more discussions in this nature. But most importantly, just really, really honored and admired to be able, to have worked with you all today, and go forth and conquer, because if we could clone you all, we'd be that much better for it. So a big thanks to everyone, and we look forward to the next discussion. Thank you.
Thank you, guys. Thank you.
Thanks very much.
Have a
Great
nice time.
sharing, Kelly.
Thank you.
Thank you.
Bye.
Bye.